your payer now looks at it and says, we want people on these things because if it's beneficial, then that means long total cost of care should diminish, right? Like if I can stop my patients from going on dialysis and having to pay for that long term, and these drugs can help with that, then we should push providers to consider these drugs as first line therapy. So your second line therapy turns into like just disease oriented outcomes or things like that, maybe not as much. Or what it could be is the second line turns into, we have another drug that's comparable, but maybe it's easier to use. Like, okay, your first line therapy has to be taken 3 times a day. So adherence is difficult there, but it's pennies, but it still has good efficacy. You have another drug that comes on the market, it only has to take once a day, same comparable efficacy. Start the person on the cheap one first. And because efficacy is going to be similar, right? The only benefit is that perceived adherence issue. But if your patient's taking the medication, having the benefit with it, then first line therapy has accomplished what it's supposed to. That second line therapy we can then reserve is the patient says, you know what, the drugs just isn't working. Why isn't it working?